So I actually thought I would get this video out a bit quicker, but I've been having a really hectic week. And this is one of the videos that I thought I had actually done on my channel, and then when I actually went through, I realized that I didn't. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at cerebral palsy. If you haven't yet subscribed to the channel, please hit the subscribe button because we have crossed 6,000 subscribers. Thank you to each and every one of you for subscribing to the channel and continue showing some support. Drop a comment, drop a like, and grab a piece of paper and your pen and let's go. So when you talk about cerebral palsy, remember that there's this injury that's happening to the young developing brain. And by young developing brain, I mean someone that's below the age of 2 years. So this injury is going to be resulting in this static, non-progressive disorder, which is going to be affecting movement. It's going to be affecting posture. It's going to be affecting coordination. And remember, this is acquired in the early development of the brain, below 2 years. And remember that cerebral palsy is actually a group of conditions. It's not really a specific disorder or a single condition, and it's actually the most common cause of motor impairment in children, and it affects about 2 to 3 children per 1,000 live births. Now remember that most of these motor disorders are going to be accompanied by disturbances of cognition, disturbances in communication, in perception, in different sensations, behavior. You may have seizure disorders. You may even have secondary musculoskeletal problems like contractures, like joint misalignment, like, of course, joint dislocations, which will be denoting certain implications on the management. And remember that even though this lesion that we've described is non-progressive, meaning that it's not getting better, it's not getting worse, but if you actually look at the clinical picture of the child, it appears as if the lesion is growing or as if they are getting worse. That's only because the child is growing and the brain is a very, very dynamic thing. But remember that the lesion itself is non-progressive. And remember that most of these injuries are going to be happening below the age of 2 because that's where most of the development is going to be happening, and injury during this period is detrimental to the child and can actually affect the child for the rest of their lives. And remember that if someone actually gets any injury to the brain after the age of 2, we refer to this as acquired brain injury. And even though the underlying cause is actually static, the motor dysfunction, like I said, will appear as if is evolving, and this may actually even give you this impression of this person deteriorating, but this may not be the case in terms of the underlying cause. And remember, whenever you're giving a diagnosis of cerebral palsy, you must have the following things in your diagnosis. You must have the distribution of the motor disorder, you must have the movement type, you must have the cause, and you must have any associated impairment. In neonates, actually, the diagnosis can be suspected if you have a baby that's fit in the bracket of this child being irritable, having these convulsions, having difficulty sucking, and even an abnormal neurological examination. And most of these children are the ones that actually are born with this hypoxic brain damage or perinatal asphyxia. But of course, some of them actually do recover and they don't develop cerebral palsy. Another percentage of them actually do develop cerebral palsy in the future. And what are some of the causes of cerebral palsy? Remember that 80% of the cases are actually going to happen antenatally or prenatally during the pregnancy. This may be attributed to either vascular occlusions, some cortical migration disorders, structural maldevelopment of the brain that may be happening during the pregnancy. There are certain contributing factors that have been implicated, which include prematurity, intrauterine disorders, neonatal encephalopathy, and even connectors. Remember that. That's why we want to deal with neonatal jaundice, because if there's a rise in the bilirubin levels, this can actually cross the blood-brain barrier. They can actually deposit in the auditory nuclei, they can deposit in the basal ganglia, and it may actually result to damage in these areas, and this may actually contribute to the child developing a certain type of cerebral palsy. Maternal risk factors include multiple gestation, preterm labor, And remember that the causes of cerebral palsy generally may be classified as prenatal, perinatal, or postnatal, but sometimes you may not even identify a cause. So the prenatal causes include certain genetic factors, cerebral malformations, intrauterine infections during pregnancy, predominantly our torch infections, radiation, cerebral infarction, hypoxia, and even some metabolic defects. Perinatal causes may include prematurity. Remember, this is a birth before 37 completed weeks of gestation. And remember that half of the cases of the children that are born with prematurity usually are going to be also associated with a low birth weight. And remember that prematurity predisposes an infant to actually develop the intraventricular hemorrhage or the intracerebral hemorrhage. It also predisposes to the periventricular leukomalacia. And these two contributing factors may actually push a child to developing CP later on. They may also have birth asphyxia as a cause. HIE, especially in the full-term infants, and remember that this tends to affect the thalamus, it tends to affect the basal ganglia, it affects the cortex and the subcortical white matter. You may also have birth trauma, you may have prolonged or precipitous delivery. Postnatal causes before the age of 2, things like hypoglycemia, hyperbilirubinemia, which may cause kernicterus, meningitis or encephalitis, subdural hematoma, acute infantile hemiplegia, head trauma, and even cardiopulmonary arrest. Now, what's the clinical presentation? Remember that this is actually quite wide, and there are numerous different presentations that have been found. And numerous children actually are going to develop CP and will actually be identified as being at risk of it early in the neonatal period. The diagnosis may not be made until maybe the first year. Most of the children are actually even much older than this when the diagnosis is actually made, but usually we have this suspicion. And what can actually raise this suspicion are certain early features that tend to be present in CP. Usually the first thing that you often notice in this child is that they're going to have this delayed motor milestones. That's if they weren't admitted prior to the hospital or they haven't been coming for review. So most of the times they'll have this delayed milestones. So they'll have a delay in sitting and rolling over. It may actually even be accompanied by a slowing of the head growth. They may also have this abnormal limb and trunk posture and tone, especially during infancy, during the first year of life. So initially the tone may be reduced, so they may be hypotonic, but eventually they will develop some spasticity. Then you may have some abnormal patterns. You may have some feeding difficulties, especially with oral motor and coordination, slow feeding, gagging, and even vomiting. Often the ones that actually develop these feeding disorders actually have a reduced life expectancy compared to those that can feed normally, because remember, you may have this affecting the corticobulbar area, or the corticobulbar involvement can actually lead to certain feeding difficulties. And usually if these feeding difficulties are quite prominent, the child may actually fail to thrive. They may in the long run even develop malnutrition. You may also have abnormal gaits once they are able to walk, asymmetric hand function before the 12-month of age. Then of course you may have this persistent of the primitive reflex, because remember these reflexes are supposed to disappear at a certain age. So you may have the Moro, the grasp, and even the asymmetric toe neck reflex being persistent. Now remember that these reflexes are meant to disappear because they're preparing the body for the emergence of these normal motor patterns. And once these reflexes actually persist, then they eventually become like obligatory, and you have these persistent. It makes it difficult to carry out voluntary movements. And the diagnosis is actually made by finding of abnormalities in tone, delays in motor development, abnormal motor patterns, persistent primitive reflex. And remember, this diagnosis may be suspected in neonates but can only be made months later. And the specific type of CP can actually be determined after the age of 2. So before the age of 2, you cannot really determine what type of cerebral palsy do they have. So there are 4 main clinical subtypes, the most common being the spastic type, which is 90% of the cases. It's subdivided into 3 main types: hemiplegia, diplegia, and quadriplegia. You have also the dyskinetic type, which is accounting for about 6%, the ataxic type, which is about 4%, and the mixed type, which can be a variant of either of these types. So we'll begin with the spastic type. So remember that here, the word spasticity is going to be meaning the state of resistance to passive range of motion. So this person's muscles are resisting passive motions. If you tell the person to relax, or if their muscles are relaxing, you attempt to stretch them out, there is some resistance. And remember that the faster you stretch these muscles out, the greater the resistance. So the resistance tends to increase with the increase in the velocity or the speed of the motion. And often, most of the times, the damage that's going to be happening here is going to be affecting the upper motor neuron, neurons, and remember upper motor neurons are predominantly or pyramidal or corticospinal tract, and these are going to result in hyperreflexia. They're going to result in spasticity, so the tone of the muscle will be increased. So these can actually range from mild motor dysfunction to even severe motor dysfunction. With the milder cases, it may actually not even be evident at rest. It may only become quite evident when they're doing specific activities such as running, while in the severe forms, it may actually even be evident at rest. Then of course you have this limb tone which is persistently increased, so you have this consistent spasticity. Additionally, you may have this brisk deep tendon reflexes and extensor plantar reflexes. And remember that muscles are very important for movement. So whenever you have this continuous contraction of certain muscles of the body, even movements that are supposed to be made voluntarily become weak and they become poorly coordinated. And like I already told you, that the spasticity is velocity dependent. So meaning if you stretch the muscle faster, there will be a greater resistance. So this is actually the hallmark of spasticity. Then, for example, if you stretch it quite slowly, you may feel some pressure until there is a sudden given, quote unquote, a given or a loss of this pressure. Then it's like the tone the contraction actually completely goes away. So we call this as a clasp knife type of spasticity. Now this is actually very, very common in this spastic type of cerebral palsy, and this clasp knife is like a special type of knife that you can actually open up. It's quite hard when you're beginning to open it up, and then when you reach a certain point, it gives up and then it quickly opens up. Similar fashion is happening here. And remember that the limb movement can actually be, the limb involvement rather, can actually be unilateral or bilateral. And as we have seen now, there can be actually asymmetrical involvement of the limbs. Most of these people that are having these constant contractions may actually have joint contractures, and they may actually also have joint misalignment. Another thing that's very important is, remember, these muscles are constantly contracting, and whenever you have this constant contraction of the muscles, these are going to be needing energy, and this energy is coming, of course, from the breakdown of the proteins, the breakdown of carbohydrates, the breakdown of fats. So often this is one of the risk factors why these patients are also predisposed to malnutrition. Not only is it because of the problem of feeding, the swallowing reflex is impaired, they are not able to feed so well, they're not so independent, but also because of the spasms and the contractility of the muscles that are using up the energy, and such that all the energy is being directed towards the contraction. So even if you eat enough food, most of the energy is being burnt out. And then there may also even be some consistent muscle breakdown because of this constant spasticity. And remember that spasticity tends to present quite early, and this may actually be even seen in the neonatal period, and sometimes there may be initial hypotonia, like I said, particularly in the head and the trunk, and these patients may also have other visual defects including strabismus. Now we'll begin with hemiplegia, which is a type of spastic cerebral palsy. So remember that in hemiplegia here there is unilateral spastic motor weakness, so it's affecting one side. So here's a picture of this child. So as you can see here, it's like this child is able to hold the ball with the left upper arm. Then you can see this is the left, then the right arm here. As you can see, it's hyperpronated, it's flexed, and you can see that the hand here is even fisted. It's not as open as this one at the bottom. So you can see that this child has what is known as hemiplegia. Now this is usually involving one side. So it's unilateral involvement of the arm and the leg. As you can see, even the leg here is not, as it's like he's putting all his pressure on this side, and this one is not even putting so much pressure on this leg. And the arm is usually more affected than the leg, with the face being spared in this type of hemiplegia. It's much more common, and most children are going to be affected during the age of 4 to 12 months, and then they're going to be having this fisting of the affected arm. It may be flexed, it may be pronated, and they may be asymmetric reaching or hand function. So if you're able to give them an object, let's say if you give a child an object that they're interested in, remember that there is a pincer grasp that's supposed to develop later on as you are in the process of development. I'll leave a card linked at the end of the video for growth and development. But once you now give this object to this child and they attempt to grasp it, they'll grasp it with the side where they're able to use the function. So if you're to give this child that's on the screen here something, they would use this other arm as compared to this other arm. So attempts to grasp will always be on the same side, on this side, and of course there'll be fisting on this side and absence of the pincer grasp on the other side. And then on this toe here, they may have a tiptoe walk, which is a toe heel gait on the affected side. And in the past medical history, it may actually be quite normal and it may be unremarkable. Usually these ones do not even have an evidence of hypoxic ischemic encephalopathy, though in some cases they may actually have had neonatal stroke. And then sometimes larger brain lesions like strokes may actually cause hemianopsia, which is loss of vision on one half of the visual field of the same affected side as the limbs. And then some risk factors that have been involved includes perinatal vascular insults, postnatal trauma, as well as CNS malformations. Then with a much more severe type is quadriplegic cerebral palsy. That's the spastic type. So this one here is actually one of the most severe of the three types. And as you can see, here is a child with spastic quadriplegic cerebral palsy. How do I know this? As you can see, if the child is lifted up, you can see the legs here. They appear like as if here they are extended and they are abducted, or rather adducted, coming together close to the midline, adducted towards the midline again like that, and they're crossing each other like as if it's a scissors, so that you see the scissoring of the lower limbs. And then also you can see the upper limbs here are fisted, or the hands are fisted, and the forearms are actually pronated. So this child here has spastic cerebral palsy. So this tends to affect the motor involvement of the head, the neck, and all four limbs. It's all four limbs that are affected severely. Sometimes they may have this opisthotonus, which is like this arching of the back. If you've ever seen an exorcism and you see that the back is arched like that, that's what we call opisthotonus. So there's this extensor posturing. They have poor head control. They have low central tone. Now, this is the most severe form of cerebral palsy, and it's often associated with seizures, microcephaly, sometimes even moderate or severe intellectual impairment. So these ones actually may actually even need to be placed in a special school. Then there may be a history of perinatal hypoxic ischemic encephalopathy, CNS infections, trauma, or malformations. And remember, here we have cortical bulbar involvement. So it means that they're going to be having some impairment in the oral, lingual, and palatal movements. This may cause dysarthria, difficulty in pronunciation of things. It may also even cause dysphagia, difficulty swallowing. This is the second reason what may result in malnutrition. Remember, the first reason that I told you is the constant contraction of the muscles, constant energy is being channeled to those muscles. Second reason is a problem with the swallowing reflex because of this cortical bulbar involvement. And remember that this is also associated with seizures, scoliosis, weakness of the face and pharyngeal muscles, gastroesophageal reflux, aspiration pneumonia, failure to thrive, and even some sensory impairments. Then we'll move on to the diplegia, which involves the lower extremities. So this is more, the lower extremities more than the upper extremities or the face. And remember that all four limbs are affected, but the legs are affected to a much greater degree than we have the arms, such that the hands have normal function relative to the lower limbs. Here you have increased tone, and remember that if both lower limbs are affected, walking is going to be abnormal. And motor difficulties in the arms are actually much more apparent with functional use of the arms, and then they may have scissoring, which is what I showed you in the previous picture. And most of these patients that have diplegia have prematurity as a risk factor, which may be associated with periventricular brain damage. Remember, here there is a history of early rolling over. So the history in cerebral palsy is very, very important. Then those are the spastic types of cerebral palsy. Now we move on to the second type of cerebral palsy, which is known as the dyskinetic cerebral palsy. Now here they have this involuntary, uncoordinated, sometimes the stereotypical types of movements, and these movements tend to be actually much more evident with active or voluntary movement or with stress. So they are emotionally dependent. The more excited the child gets, the more evident these movements will actually be. This is the second most common type of cerebral palsy, and it tends to affect the arms much more than the legs. So here the muscle tone may be variable, and the primitive motor reflex pattern may actually predominate. Now here there are three important terms that I want you to be able to distinguish. There's what we refer to as chorea, there's what we refer to as athetosis, and there's what we refer to as dystonia. So when you talk about chorea, this is just simply this irregular, sudden, jerky, brief, non-repetitive distal movements, okay, non-repetitive. Then athetosis here, these are slow writhing, or you can say slow twisting like movements that occur in the distal areas, which can be like, for example, fanning out of the fingers repetitively, and this is what we refer to as athetosis. Then dystonia is where we have this simultaneous contraction of both the agonist and antagonist of the trunk and the proximal muscles, which is going to give this child a twisting like appearance. So this is what we often see in patients that have dyskinetic cerebral palsy. And remember that these are going to be much more evident when there's voluntary movement or when there's excitation. So if there's an increase in emotional tension, they will be much more evident, and they tend to disappear when the child is actually asleep. Then in this patient's intellect may actually be relatively unimpaired, so they may have a near normal intellect. And then of course the affected children often are going to present with floppiness, poor trunk control, and delayed motor developmental milestones in the infancy. They may have abnormal movements which may appear towards the end of the first year of life. And remember, dysarthria is also common and it's actually quite severe. All these signs are because there is a problem or a damage to the basal ganglia. And you also have pathways in the basal ganglia which we refer to as the extrapyramidal pathways, which tend to be affected. So it means that one of the common things that can actually cause this is kernicterus. That's the hyperbilirubinemia, which can actually deposit inside the basal ganglia. And we tend to often see this with rhesus disease of the newborn, but now even HIE at term can cause this. And remember that children with athetosis due to kernicterus also are going to be having this neurosensory deafness because there is also damage to the auditory nuclei. They also have this upward gaze paralysis. Then we move to the last type of cerebral palsy, which is known as ataxic or hypotonic cerebral palsy. So this one here is mostly genetically determined. So here, when we get this acquired brain injury, often it's going to be affecting the cerebellum and its connections. And remember, the cerebellum is very important in certain things that have to do with movement, adjustments of movements, especially with fine motor movements and these rapid motor movements. Then of course there are going to be signs that are going to occur on the same side where the lesion is, and usually the defects are usually rather symmetrical. Then there is going to be early trunk and limb hypotonia. There may be poor balance, because remember the cerebellum is also important for balance. There's going to be poor balance. There's going to be delayed motor development. There's going to be weakness, uncoordinated movements, intentional tremors, and there's going to be an ataxic gait that may be actually evident later on. And because of these things that are happening, and this child is imbalanced, when they stand still, actually you see that their legs are spread wide apart. They have this wide based gait, and they have these difficulties in performing rapid or fine movements, which we call dysdiadochokinesia. I don't know if I actually butchered the word or actually said it quite right. You should actually look that up. Then we do have a mixed type, which is actually has a proportional of certain features, and most of these actually is going to be spasticity and athetosis, and most of these children also are going to be having severe intellectual disability. Now here's a summary of the types of spasticity. So here in the types of CP, here we have hemiplegia. Here we have diplegia, so this is affecting the lower limbs more than the upper limbs. Here is affecting one side of the body, and we have quadriplegia, which is affecting all four limbs. Oh, this is actually what we've actually been talking about in the previous slides. Then how do you make a diagnosis? Remember that this is made on clinical grounds with repetitive examinations, and often this is supported by your history. So if cerebral palsy is actually suspected, we should actually determine the underlying disorder. So a history is very important. The birth history is actually very, very important in all CP patients. So remember, the diagnosis is going to be suspected in the bracket of a child that was born with a low birth weight or even any perinatal insults, and clinically they have increased tone, they have feeding difficulties, and they have global developmental delays. That's when we can actually have a suspicion that this child may have cerebral palsy. Then the abnormalities of tone, posture, involuntary movements, and neurological deficits should be recorded, and these become actually a bit evident after the age of 2. And remember, as we said, the diagnosis can sometimes be confirmed during early infancy, but the specific type cannot be characterized until someone is at the age of 2 years. There is a certain tool that you can actually use, which is known as the Gross Motor Function Classification System, expanded and revised tool, which actually divides CP patients according to the gross motor movements into 5 different groups. So this actually helps us to actually have a good description of the current motor function. It helps us also to identify the current and the future needs for mobility aids. So you can actually Google this up and actually look at how it works and have a few details of that. I won't go into that because that'll be out of the scope of your syllabus at this moment. Then we also want to get a CT scan or an MRI scan. And this actually is very important actually in demonstrating these cerebral malformations and delineating their extent and actually even ruling out other progressive things or other things that are actually treatable, things like tumors. Do not also forget to rule out any inborn errors of metabolism. So screen for plasma amino acids, urine organic acids, and reducing substances, reducing sugars. Remember that if you get a high-risk child, and what do we mean by a high-risk child? Anyone that has evidence of asphyxia, perinatal asphyxia, stroke, periventricular abnormalities that are seen on the cranial ultrasound, especially in those that we do in preterm infants, any jaundice, meningitis, neonatal seizures, hypotonia, or reflex suspension. All these children are considered as high risk and you must follow them up closely. Up until, most literature says until they reach the age of 2, but we can actually even follow them up beyond this just to be on the safe side. Then what is our differential diagnosis? So it could be neurodegenerative disorders. Remember, these are going to be having this progressive increase in symptoms. They tend to be familial, so they'll have a familial pattern. They tend to be heredited, so there will be some consanguinity. Then of course there may be some specific constellation of signs and symptoms that can give you a clue towards the neurometabolic disorders. So they may have failure to thrive, vomiting, seizures, which are rather significant symptoms. And then of course further lab investigations may be needed. Hydrocephalus and subdural effusions. Here they tend to have a head size that is large, a fontanelle that is bulging, and sutures that may be separated. You may also have brain tumors or space-occupying lesions. They'll give you features of increased intracranial pressure. You may have certain muscle disorders like congenital myopathies or muscular dystrophies that can actually mimic cerebral palsy. But remember that the distribution of the muscle weakness and other features is actually characteristic. Remember, hypotonia is associated with diminished reflexes. Sometimes you may have ataxia telangiectasia, where you get this ataxic type of movements that are appearing before the ocular telangiectasia is actually even evident. And also you may also consider spinal injury in some cases. Now, how exactly do we manage these children? Remember that it must involve the parents, and the parents must be given as much detail as possible. And you must stress that the child is probably going to live with this condition for the rest of their life. There is no cure, but what we can actually do is actually help the child become much more independent. So the parents might actually be given full details of the diagnosis as early as possible, and the prognosis is actually very difficult to actually determine during infancy until the severity and the pattern of the evolving symptoms and the child's developmental progress has become much clearer over the several months or years. Like I said, a good benchmark is to wait until the child is above the age of 2. So it's not really possible for us to actually have this prognostic indicators before the age of 2. So management plans should actually be drawn up. It should be holistic and should involve the family. You're going to involve many wide range of other professions. So this child may actually need physiotherapy, and remember, this is going to be dealing with handling and mobilization. So they may also be having things like stretching, strengthening, or even facilitating good movement patterns, and these often tend to minimize the effects of spasticity and to prevent contractures. You may also have some bracing and constraint therapy and certain medications that may be added. You may also need occupational therapy, which is going to be advising on certain equipment like wheelchairs, the seats that this child actually needs, the play material, activities that actually best encourage the child's hand function. You may also have speech therapy. Pediatric management is very important. Here, this is where now you are going to come in as a pediatrician to monitor this child's fetal developmental progress, to check for every medical condition. Remember, malnutrition is one of the important things that most CP patients actually come to the hospital with. So medical problems, development of contractures, you must look out for these things. Any dislocations, you must look out for these things. Any behavioral difficulties or any nutritional status problems. Then of course, nutrition is very important. So the feeding methods should be assessed, because sometimes it may be difficult to feed these children, which is another reason why they may develop malnutrition. And of course, nutritional caloric assessment is also needed. Orthopedic surgery is sometimes also needed, for example, in the management of dislocation of the joints with high spasticity in the hips as well as in the thigh abductors, then adductors rather, and also fixed equinus deformity of the ankle as a result of the spasticity in the calf muscles. And remember that these children that actually have CP actually need quite a lot of help in this basic day-to-day tasks. So things like dressing, bathing, feeding, those that actually have a milder form of CP can actually cope quite well in the mainstream schools and have actually minor learning difficulties, and physical access actually is actually not really so much. They're so independent on their own, but rather these ones who have severe type of CP actually need to go to the special schools, then the schools for the disabled people, specifically schools for those that have disabilities and schools for those that have CP. We can sometimes give certain medication. Sometimes you can inject botulinum toxin into the muscles. This actually even helps to decrease their uneven pull on the joints and actually helps even prevent the fixed contractures. We can give certain medication like baclofen, which is I've seen being given. Benzodiazepine, not so commonly given. Tizanidine is not also commonly given, and dantrolene sodium, which also is not commonly given. The one that's commonly given in our setting here is baclofen, which may actually diminish the spasticity. So remember that baclofen is a GABA analog, and so it's going to be working as a skeletal muscle relaxant. It's also going to be working as an antispastic agent. So it's going to be relaxing the muscles and also relieving the pain and the discomfort which is due to certain nerve disorders. It's also used, by the way, in other nerve disorders in older individuals. And how exactly are we going to give this? So remember that the dose must actually be gradually increased, but if you see that there's no benefit within 6 weeks, you can actually discontinue the drug. So in children, we can actually start at 0.75 to 2 milligrams per kg daily, and over 10 years, a maximum dose of 2.5 milligrams per kg daily. So in a day, they should receive 2.5 milligrams per kg. So it means if they are weighing, for example, 10 kg, 10 multiplied by 2 is 20 milligrams. So in a day, they should receive 20 milligrams as a total dose. Or you can start off at 2.5 milligrams 4 times a day daily, then you increase gradually until you reach the maintenance for their age. So if there's 1 to 2 years, it's about 10 to 20 milligrams per day. If it's 2 to 6 years, it's about 20 to 30 milligrams per day. If it's 6 to 10 years, about 30 to 60 milligrams per day. Then for the adults, 5 to 30 milligrams per day. But remember, with a maximum dose of 100 milligrams per day. Remember that this is contraindicated in patients with epilepsy. It's also contraindicated in patients with rheumatoid arthritis. And then the drug of choice actually for the most effective treatment for severe spasticity, you can actually give this baclofen as intrathecal, which is within the CSF, within the meninges. Then this is actually going to be given via the subcutaneous pump and the catheter. This is actually the most effective treatment. Now, what about the prognosis? Remember, this is going to largely depend on the degree, the type of cerebral palsy, the level of learning disability, and the presence of other associated problems. So the degree is going to be independent of or the degree of independent living relates to actually the type and the extent of the cerebral palsy, the degree of the learning disability, and even presence of any other associated problems. So if they do have these things, then the prognosis is rather poor. But if they don't, most children will actually survive into adulthood, and even the severe limitations such as sucking and swallowing, these are the things that are actually going to be decreasing the life expectancy, because these children may actually need a gastrostomy feeding tube. Remember that the goal of the management and the goal of these CP patients is you want to help them develop maximal independence within the limits, such that they can actually work with their motor disabilities and even the associated defects, and with actually this appropriate management. And many children that are actually with CP, especially the spastic, diplegia and hemiplegia, most of these can actually even live a near normal life. So here's a summary of everything that we have actually talked about, from the prevalence, the etiology, the diagnosis, the associated problems, and the prognosis. If you enjoyed everything in this video, consider subscribing to the channel. You'll never miss out on such amazing content. Hit the like button if you really enjoyed this video. Drop a comment also to show some support. Thank you for the 6,000 subscribers. I know it actually took us not so long, but very soon the channel will actually be crossing 2 years, and I really want to take my time to actually appreciate each and every one of you that has shown support to the channel and that keeps showing support to the channel. Please keep doing that. You are actually doing the most for the channel, and I appreciate each and every one of you. Until the next video, my name is Dr. Moses Kazevu. Until next time, bye-bye.